Okay, so today we're going to discuss the chapter 3, all about the introduction to your urinalysis. Okay, so this topic will be discussing about the the first one. We have here the different historical milestones happening in the development of the urinalysis, followed here by the urine composition and for urine formation, and we'll be discussing as well here the different method of your specimen collection for the urine. Okay, so we have here some of the historical milestones that happened throughout the history of the urinalysis. So we start here with the ancient writings. Okay, the Edwin Smith surgical papyrus, which try to provide or describe here or provide a picture with the physician to try to hold a flask, and the flask here contains the urine. And that would signify that even during the ancient time, urine testing is being done by the physician. Then we have also here the chemical testing for the urine is being done here by, especially for determination if the patient is diabetic or not, with the glucose testing. It's being done by ANT testing. So of course here, if the urine of the patient would have a very high level of glucose, then the ants will be attracted to that. Another one, taste testing. So titikman nila. So yan, pag matamis din, diabetic patient. Kadiri nga lang. Then we have also here the development of the discovery of the albumin testing by Frederick Decker. So try to identify the presence of the albuminuria by boiling the urine. So currently, we try to know here if the patient would have a high level of the albumin, the protein, by boiling. So it would have here much cloudiness or precipitation. So pag madaming too turbid, too cloudy na specimen after boiling to, it would signify that the urine of the patient would have a very high protein concentration. And then also they try to develop here the method of the quantitating the urinary sediment and become part here of the Addis count. Become here the basis for the reporting of the urinary sediments. Okay, how you report the number of the WBC or the RBC or the different cellular sediments present in the urine sample. Okay, as of today, although the urine testing here or the urinalysis is still part of the routine uh, test being requested by physicians. Because of number one, the procedure itself is very inexpensive. However, here the result of the urinalysis here provides different metabolic functions of the body of the patients, and as not that so expensive na test procedure, but then again it would provide us with some information, several informations actually of your functions in your body. Second one, so still popular because of course here it is easy to collect. So anytime the day you can collect the urine and eventually become your sample here for the urinalysis. Okay, then we have here the urine composition. So basically our urine, 95% of that is made up of the water. And the remaining 5% is made up of the dissolved solutes. So the solute here could be in the form of your organic or inorganic substances. But aside from the solute, that could also be being added here by other cellular sediments. Like your urine could be added with the WBC, with the bacteria, for example, if you have a urinary tract infections, your urine could also be being added here like mga epithelial cells or even CAS or even urine crystals. So especially if there will be an additional medical conditions associated with the patient, aside from this water and the dissolved na solutes. Out of your 5% solute, so it's made up of the organic and inorganic substances. The organic substances we have here, high level of that will be made up of the urea. Again, urea is the major product of your protein catabolisms. Followed here by creatinine, uric acid, and we have your hippuric acid at that one is at the decreasing concentration. So mean to say the urea would have here the biggest portion of your organic, actually constituting here almost half of your organic solute. Then followed here by the creatinine, uric acid, that will be a decreasing concentration. For the inorganic here are actually your salts, your electrolytes, or your ions. So this includes here your sodium chloride, your potassium, your sulfate, your phosphate, your ammonium, your magnesium, and your calcium. Okay, so another thing about the urine, so sometimes here, if we are in doubt if the submitted sample the patient's the urine or not, because of course there are some other body fluids that would resemble just like your urine. To make sure that one is a urine, then you can check for the level of the urea and creatinine. Urea and creatinine supposedly are very high in the urine sample. So again, if the body fluid submitted is a urine, then if you test for the urea and creatinine, that one will be much higher compared with your other body fluids. So pag mataas siya, so okay, that's urine sample. Okay, the next one, we have here the urine volume. So we have here the different factors we try to determine the volume of the urine output. Most likely kasi, regardless of these different factors, most likely your urine output is highly dependent, most likely, in your amount of the water intake. Okay, so that's highly dependent on the body's state of hydration. So the following here, number one, fluid intake. So it would mean here that the more water you try to take in, so you are expecting that you have more urine output. Another one, we have here fluid loss here from non-renal sources. Another factor would be the concentration of your antidiuretic hormone. So remember that your antidiuretic hormone is try to be responsible here for the water reabsorption in your collecting ducts. Then we have also here the need to excrete large amount of your dissolved solute, which includes here the glucose and your salts. Okay, we have here the normal urine output. So we could have here as a range, you could have here daily urine output could be at 1,200 ml to 1,500 ml, but it could have here a range of 600 ml to 2,000 ml. So this range here become the basis if you are having or able to excrete here normal urine volume or not. Okay, based on that volume, so we could classify the urine output as the following. Number one, we have here your oliguria. So oliguria is defined here as decreased urine output. Okay, so paano magiging classification natin if you have this oliguria? So if you're adult, if your urine volume excretion here is only less than 400 ml per minute, per day pala, less than 400 ml per day. For the infants, that should be less than 1 ml per kilogram per hour per day. And for the children, should be less than 0.5 ml per kilogram per day. So we have here the reasons why you have a decreased urine output. And most likely that's one associated with your dehydration or because of increased loss of the water in your body. So why you have here much of the water is being lost in your body? Number one, because of the diarrhea, so tae ka ng tae, or suka ka ng suka, we have your vomiting, increased perspiration, so, and we have also severe burns. All of that would result here to increase water loss in your body, and that result also here to decrease urine output. Then we have here the term anuria. Anuria is the absence of the urine output or simply the cessation of the urine output. Mean to say you are not producing urine. Okay, why? Because number one, it may have because you have a damage or kidney kaya hindi ka makapaglabas ng iye. Another one, wala ka na produce na urine output is because wala namang sinusupply na blood ang ating heart to your kidney. So remember that your urine is an ultrafiltrated plasma, so galing siya sa blood natin. So kung may problem with your supply of the blood that is being pumped by heart going to your kidney, like in the case may congestive heart failure ang patient, so nahirapan siyang circulate ang blood. So expect also here that walang pumapasok na blood sa kidney and therefore wala kang urine output for that. Then we have also here the nocturia. Nocturia here is an increased urine output here or urine excretion during the night time. Usually kasi you are urinating 2 to 3 times during the daytime compared to the nighttime. Pero pag dumadami ang urine output mo during the nighttime compared to the daytime, then we consider that one as your nocturia. Another one, we have here the polyuria. Polyuria is increased urine output. So what would be the basis for that? If you are adult, if you are excreting more than 2.5 liters per day, or for children and infants, that's more than 2.5 to 3 ml per kilogram per hour per day. Okay, per hour per day, that would also consider here as the polyuria or increased urine output. Okay, then we have here the causes of your polyuria. So most likely there are two medical conditions characterized here by an increased urine output. One is your diabetes mellitus. The other one, we have your diabetes insipidus. Then it could also induce here increased urinary output by your diuretic drugs. So we have also your caffeine or even your alcohol consumption or even cold temperature. It also induce here much of your urine excretion. So we have here your diabetes mellitus versus your diabetes insipidus. Diabetes mellitus here, medical condition characterized by absence of your insulin production. Diabetes insipidus, on the other hand, characterized here by absence of antidiuretic hormones possible for the water reabsorption in your collecting ducts. As for the urine volume here, both of that medical condition would have an increased urine output. Only that in diabetes mellitus, the urine here is much concentrated, higher specific gravity compared with your diabetes insipidus that would have a decrease or lower specific gravity because that one would have here diluted na specimen. Most likely sa diabetes insipidus, you have your high specific gravity because again, madami kang dissolved na glucose. So, mabigat ang glucose and therefore, it would increase the specific gravity reading of your urine output in a patient na may DM. Okay, for the glucose level here, so that will be high in the diabetes mellitus but not in your diabetes insipidus. Okay, then we have here the specimen collection. So, basically, when we are collecting the urine, so the ideal container for that should be a wide mouth container with a cover. It should be wide mouth to facilitate the urine collection, especially for the female na patients. Okay, so approximately we have 50 ml of that, but the 12 ml is already enough then for you to perform here all your tests, including your chemical examination up to your microscopic examination. Specimen labeling, so we have that one. Of course here, the specimen container should contain the patient's complete information and the label here should be put on the body of the container and not on the cover. Kasi baka pag binuksan mo, pag nasa cover, baka magkamali ka pagbalik mo. Another one, specimen rejections. These are actually, it should be stated in your standard operating procedure in the laboratory of the grounds for your rejection. Baka may magreklamo na patient na bakit mo hindi mo tinatanggap ang specimen ko? Then okay, based on our standard operating procedure, ganito. These are the grounds kung bakit magre-reject ang specimen. So, para hindi makareklamo ang patient. The first one, unlabeled. So, we do not assume here that specimen is always for that patient unless na may label ito. And a specimen should always be accompanied here by the requisition slip. And it should match the label of that requisition slip with the label of your specimen. Another one, QNS, quantity not sufficient. So, pag quantity not sufficient, so less than 12 ml, because of course, it will not facilitate the entire testing process. So, like, for example, sobrang konti ng specimen niya, pag nag-strip tayo, gumamit ng strip, hindi siya aabot sa taas, hindi mo ma-strip lahat ng chemical test pads. So, hindi mo matest, so that will be insufficient. Another one, contaminated na urine, so especially for the baby, for example, so they will have always the challenge to collect the urine from the baby because it might, especially pag babaeng patient, so it might have the tendency that the urine sample is being contaminated by the fecal sample of the patient. So then another one, not properly preserved na specimen. So when you're collecting the specimen, the patient should deliver the specimen to the laboratory within 2 hours of the collection process. Pag more than 2 hours, so you need to reject that one because of course here, unpreserved na specimen would have a different effects, especially for the different chemical constituents and even the cellular constituents dissolved in your urine sample.